Hi, and welcome back to yet another session wherein I discuss all the obstetric dilemmas or pet peeves. So, until now, I have discussed 3-4 pet peeves in the previous few sessions, but today it is something that I'm going to discuss which not a lot of people implement, but it's a good, very good clinical practice. Evidence backed, definitely, but still, there's a significant dilemma. There are various dilemmas. Until when do I have to do that? What is the dose of doing it? And does it really benefit? Today, I'm here to clear all of those dilemmas, and the topic is going to be a great topic, magnesium sulfate, but for neuroprotection. Now, we all know that magnesium sulfate is a life-saving drug when it comes to eclampsia and severe preeclampsia. We do give it in Preterm and Zuspan regimen. But there is one more added advantage that we just read as a solitary line during our undergraduation and even during post-graduation. Although in post-graduation you do give it for a lot of patients, but not a lot of hospitals follow it. What is it exactly? Before I go there, let me just talk about how does magnesium sulfate help in first place, or in any patient, be it a fetus or a mother, how does it help? It has 5 major actions or mechanisms of action. The first one being A, B, C, D, E is how I remember. So the first one being it potentiates adenosine. Second, it will have GABA B activation, which is an inhibitory neurotransmitter. Then it has calcium channel blockade and NMDA blockade, and lastly it also blocks glutamate release. Now these are the 5 ways in which magnesium sulfate acts, and it acts on our brain. But that is going to be beneficial in all sense. All these 5 mechanisms are going to help the mother. What about the fetus? So now in fetuses who are extremely premature, you have to remember that their brain, their neurons, especially in their brain, are highly excitable. And let alone that, these babies often tend to suffer from hypoxia. It can be intrapartum hypoxia if you're giving them vaginal trial, or post-delivery when they are delivered after LSCS or by vaginal trial, if they get respiratory distress despite the steroid cover, or if you have not been able to give steroid cover. Now this distress or this respiratory distress or this hypoxia overall is definitely not good for the fetal brain, more so because it is preterm. What happens? So this hypoxia actually goes and attacks the neurons. These neurons, because of that hypoxia, start releasing glutamate, and this glutamate goes and attaches itself to NMDA receptors. These NMDA in turn activates your calcium channel blockers, and the calcium channel blockers start releasing out all the proteolytic enzymes and free radicals, and it also destroys mitochondria. It basically causes mitochondrial dysfunction. All these mechanisms will be very bad for the brain matter, and it starts destroying, or it starts excessively activating or exciting the neurons. This leads to neuroexcitation, which is excessive. We also call this as excitotoxicity of the fetal brain. Now, if you remember all the ways in which I mentioned, it included glutamate, NMDA, calcium channel blockers. These 3 receptors wherein magnesium sulfate acts on. So the magnesium sulfate, when it is given to a patient, when there is a chance of a preterm baby being born, it is going to help cause neurostabilization of that baby, and even after it is born, there is going to be a good chance that its brain is going to be preserved from this hypoxic brain damage and also from seizures. Who do you give it to? So you only give it to very preterm or extreme preterm fetuses. Until now, the evidence said that you can give it till 30 weeks, but now most, be it RCOG, be it ACOG, Canada or Australia, most of these guidelines say that you can still give it till 32 weeks of gestation, definitely under 30 weeks. I personally prefer to give it till 32 weeks of gestation. Apart from what is the dose in which you give it, the dose is very similar to Zuspan regimen, but you do not call it Zuspan because Zuspan is for severe preeclampsia and eclampsia. But the dosing is same, wherein you give 4 to 6 gram, you can just remember it as 5 gram because it is in the Zuspan regimen, of loading dose intravenously, and then you will be giving 1 gram per hour for the next 24 hours. For it to have some action, it is better initiated at least 4 hours before the baby is born, and it has to be given maximum for 24 hours. You do not repeat the dose if the baby is not delivered in the next 24 hours the way you repeat those steroids. You call it the rescue dose. You do not do that with magnesium sulfate because MgSO can also lead to fetal osteopenia. So it is to be given only once, and if the baby still doesn't deliver in the next 24 hours, it's okay. That's not an issue. So that is it about magnesium sulfate as a neuroprotective agent. Excellent agent. It helps in preeclampsia, severe preeclampsia, eclampsia as a anti-epileptic drug. It is helping the fetus for its neuroprotection. It also has a little bit of the activity that helps in tocolysis and prolonging labor, so that preterm birth you can just gain a few more hours for steroid action or for the neuroprotection of magnesium sulfate. Apart from all this, remember it is also something that dilates the vessels, so it also improves the fetal blood circulation ever so slightly, and that is also a little bit of an advantage, that it prevents as much as hypoxia that could have occurred. And also it is an antioxidant, so all in all it's a great thing that is to be given for all those fetuses who are at a risk of being born before 32 weeks. So make sure that you do that and you incorporate this in your practice. This is Dr. Aditya, who has solved yet another dilemma for you with conceptual OBG. Keep watching us and we'll come up more of these every week. Thank you.